Hello everyone, and welcome back to Rheumatology for medical student and intern. And today our special guest again still Aline. Aline, how are you today?
Good, Dr. Tran, how are you?
Fantastic. We're going to talk about a very interesting case today about back pain. Why don't you go ahead and tell us?
Sure. So today we had a patient that presented to our clinic. She was a 23-year-old female who had back pain for several years since high school, right? And she was complaining about morning stiffness and saying that her pain is worse when she is less active and gets better throughout the day when she is more active. And so she's also has been taking naproxen that has been helping her slightly.
So this young patient having back pain for years, right? And she tried many medication and didn't work. So
Right.
what next?
Well, I think notable thing was looking at her history. She has a family history positive for psoriasis in her brother,
Psoriasis.
and a history of uveitis when she was a little bit younger. So it's been several years that she has this issue, and usually in young adults who have this chronic back pain that is made worse with no movement or inactivity, and that improves with NSAIDs, we start considering a spectrum of diseases called Ankylosing Spondylitis. And Ankylosing Spondylitis is a spectrum that has 4 diseases within it, pretty much. The first one being Ankylosing Spondylitis and psoriatic arthritis, inflammatory bowel disease associated arthritis, and reactive arthritis.
Wow, that's very nice that you can spell all of them, all the names. Because when we talk about ankylosing spondylitis, kind of mumbling, right?
Right.
It's hard to pronounce. But basically, this is a type of autoimmune disease that will attack the backbone. And because of that chronic inflammation, those tendons that connect between the vertebral body, somehow they become inflamed. And over time, if we don't treat, they will become really stiff.
Right.
In fact, you will see, like the X-ray we saw right here, we call bamboo spine.
Yes.
So that's how severe the back pain could be. So what else? What's interesting about this patient that we saw?
So in this patient, it was interesting that her pain improved with movement, and it was worse in the morning. She had a lot of stiffness and pain with inactivity, actually. And I think that kind of pointed to ankylosing spondylitis for us.
Usually, AS or ankylosing spondylitis is a condition that we try to treat back pain for many ways, and then the back pain did not improve. So for anyone out there, back pain in younger population, morning stiffness, like really frozen back, they can't move, then you should think about some type of autoimmune disease, because the longer you wait, you don't either diagnose it or you treat, the inflammation of the backbone will worsening over time, and that can lead to serious consequences. So how do we diagnose this condition, Aline?
Sure. So in the spondyloarthropathies, you can diagnose it by having a imaging modality. So plain radiographs that point to like a bamboo spine, which is kind of late part of the disease.
Very late. I would say very late.
And some other feature. And or you can have a positive HLA-B27 that's strongly associated with spondyloarthritis, plus 2 other features. And these features include things like arthritis, dactylitis, any kind of tendonitis. Most likely they complain of Achilles tendon pain, even uveitis, a family history of a positive HLA-B27.
Wow, it sounds like there's a lot of criteria, there's a lot of things that you can make diagnosis, but the key point from this case is chronic back pain, not improved with NSAID, and then morning stiffness, younger population. You need to do some imaging. You talk about X-rays, and you can see this, we call fusion between vertebral body, but that's too late. Do you know anything we can make it to make an early diagnosis?
Right. So if the X-ray results don't reveal anything, which 40% of the time they don't, we can do an MRI for the patient.
MRI, yes.
Yes. Can you tell us what we expect to see on the MRI, though?
Yes. So when you guys do an MRI of the lower back and also thoracic spine, make sure you do both thoracic, the upper and the lower, and lumbar spine. What you will see in ankylosing spondylitis is you see bone marrow edema, basically swollen, inflamed of the bone. And by doing that, you will see an early diagnosis. And I think that somehow we can make a difference. Other than we just wait until you see the bone become fused on X-ray, it's too late. Of course, we combine the clinical diagnosis, history, and then imaging and everything together. On the exam, on clinical exam that you saw today, we try to see if the patient is able to bend backward, we call flexions, or extensions, or to the side, and decrease flexibility of the backbone while making the pain worsening could be an early sign as well. So combine those together, you make an early diagnosis of AS, ankylosing spondylitis.
And Dr. Chan, how do you differentiate this between something like rheumatoid arthritis?
Excellent question, because sometimes you cannot.
You
can obviously order labs, make sure this is not rheumatoid. You check rheumatoid factor, Anti-CCP, set rate, and a lot of times those could be normal. And then still back pain, then you do imaging, and then you think this is AS. Remember, rheumatoid arthritis can cause back pain too.
Of course.
Yes. So in that case, if the patient have rheumatoid arthritis and then evidence on the arms, the wrist, and then they could see on the back pain. So sometimes it's easy, sometimes it's not easy. And that's the beauty of autoimmunity. Nothing clear. You have to try this to see this, and if that doesn't work, try other lab or imaging modality to evaluate the disease. All right, so Aline, let me ask you more about, because you're going to become an ophthalmologist, right? So uveitis and ankylosing spondylitis. How often you see someone present eye problem and then back pain?
I'm not sure.
You're not sure, right?
No.
And sometimes it's hard to put together, just like autoimmunity, because you may see someone present with eye pain and then back pain. So the moral of the story is think as a whole person, and if you see a patient with young age, chronic back pain, morning stiffness, and or eye problems, you think, oh, this is multiple system and morning stiffness, think about autoimmune disease, and that could be AS, ankylosing spondylitis. Anything else you want to share with us?
Like we asked more in-depth questions to our patient today, and we found out she had
exactly
iritis.
Exactly, and that's what we like to share with you. History, again, will tell a lot about the patient. This is especially true in rheumatology. Taking a good history will tell you a lot about the patient condition, as well as the reason why they have pain. Anything else?
So once we make this diagnosis, how do we treat these patients? What's their prognosis? And how can we make their pain better?
Wow. In this situation, the treatment would depend on the patient's symptom severity. In general, when we talk about autoimmunity, a lot of time we have to see how severe the disease impact patient life. In this particular case, her back pain, how does it impact to her life? What are her job? What is her functions? Was she able to run? Was she able to sit up, tapping, a lot of things. That's why I asked those questions. So depend on the severity of the disease, we give NSAID, we give medication to control her pain, or we send her to physical therapy for sure. But then we move one step further, we use biologics. Have you heard about that?
Yes, like disease-modifying agents.
Exactly. Or we more advanced, we use monoclonal antibody or anti-TNF, or any particular drug that blocks just that pathway. We call IL-17 inhibitor. So those are the newer drugs, basically to inhibit the inflammation process. By doing so, you have less antibody attack to the backbone, and hopefully the inflammation will slowly, and then because of that, the patient's symptoms are improving. Now, few of them you may heard on market on TV, Humira, Enbrel, Cimzia. Those are the drugs that often are seen on TV and treat ankylosing spondylitis. The bottom line is depends on patient symptom, depends on how severity and also other factor. One thing when you study biologic agents, make sure to test for hepatitis B, C, and tuberculosis, because those agents will suppress their immune system. If we're giving a medication that suppresses the immune system, they may be more higher risk of other infections.
Right.
Anything else?
So how often do you see this condition in your clinic?
Not very often, because a lot of time younger patients, back pain, you think this is back pain, right? And then give medication, and then it doesn't work, go back and treat more back pain.
Right.
So if you see a patient like this, make sure you work up further or send to rheumatologist, because we will do a full history and make sure that we don't miss autoimmune disease that may cause back pain, such as ankylosing spondylitis. A lot of time we underdiagnose this condition, and because of that, many patients came to see me either too late. They have AS for several years.
Right.
When you're having such a long time autoimmune disease like this, and the damage to the backbone is too far away, it's hard to reverse, or it's even hard to slow. So hopefully, when you listen to this case, you make AS or ankylosing spondylitis is one of your differential diagnoses. When you see young patient, chronic low back pain or upper back pain and morning stiffness, those are the early signs to make sure that you won't miss it. Right. Anything else, Aline?
That's all. Thank you, Dr. Chen.
Well, thank you, Aline, as usual, and welcome to Rheumatology for medical students and interns.